So who do we have for discussion right now?
So Nargis had signed up to participate tonight.
Okay, do we have any residents who are willing to play the game with us today? It's going to be a very mildly warm seat. Don't be shy, residents. Any other residents in the audience? Please join us. This will be fun. Nargis, why don't you introduce yourself in the meantime?
Okay, hi. My name is Nargis. I'm actually third year internal medicine resident from Buffalo.
Excellent. Is it cold up there yet?
Oh yeah, we snowed already. We have snow.
You already have snow. I think that's why I live in Alabama. I really hate snow. But I've always heard good things about that program. Do you have any other residents who are willing to stick their neck out? Well, if you don't mind, Nargis, it'll just be you and me for a little while, and then we might ask the chat for their opinions on things. Does that sound okay?
Yeah, go ahead.
Okay, so this is a case that I saw about 8 or 9 years ago. So it's a 40, you can see it right here. It's a 40-year-old woman who has had significant vomiting and a poor PO intake. So the first thing that I like to do is just have you go over all the numbers, and then just from the numbers in the BMP, discuss what you're thinking, what your concerns are, what you would do, what other tests you would get, etc.
So I'm really concerned about that low potassium. It's 1.9. So risk of arrhythmia and everything is very critical. So I'll initially start replacing that potassium before doing anything else. Also, this PMB, the sodium is low, is 120. So I'll do the workup for the sodium. I'll start with the serum osmolality. I know usually we start from the labs here, but sometimes like if I'll just go do a quick physical exam to the patient to assess his volume status and to make sure he's stable or unstable, like vitals.
If I remember right, in fact, I do remember right because I have it right in front of me. The pulse is 120 and the blood pressure is 100/60. Explain to everybody why you asked about that and how you're going to use that information.
So this is like admission. So this is will decide if the patients are stable for the floor or need to be monitored in the ICU. It could be the patient, he could be in shock. I would think maybe hypovolemia, especially with the vomiting, oral intake. I'll think maybe severe dehydration. I don't have enough data about the patients, but it could be that's like very severe malnourished patients. Maybe it's like, as I said, I will concern about shock mainly. So if the patient's blood pressure will be like lower than this, usually, I mean, some situation, I'll just admit this patient to the ICU if like, I'll think he is not stable for the floor. He needs like the potassium to be replaced, and we need to check him like close monitoring and see how's his labs and replacement. So I'll get even more history to see about what's other medical condition this patient has, what type of medication she's taking. Sometimes patients they develop vomiting, they continue taking their medications. I would think like diuretics. Sometimes I've seen patients continue taking their diuretics and they are like start having even like just gastritis and they continue taking their medication and that put them like in severe dehydration. Um, so
Okay, so I'll give you a little bit more information. So the only medication this patient is on is ethanol. She and she
this was like the first thought came to my mind. This labs look like someone has alcohol use disorder.
Explain that because you're a third year, so you look at these labs and say, I bet this is a drinker. What
with the hyponatremia, like I would think with the hyponatremia that's mainly, and also the heart rate, the patient could be withdrawing, especially if he's like heavy, he drank like heavily or like drink daily, and it's depend on the patient. But with
okay,
the
wait. Time out because this is driving me crazy. This is a she.
Oh, sorry. I'm sorry. I mean, she, I know. I just went on. Yeah. So so with the hyponatremia, that's what would be my concern, that the patient, she may be drinking like heavily. And the heart rate, she could be in withdrawal. So,
okay, so let's go back to the labs because this is supposed to be about the labs. So you're concerned about the potassium.
mm-hmm.
What acid-base disorder would you expect in someone who's been vomiting a lot? And she's been vomiting a lot.
So it's 9 GAP metabolic acidosis, I would think.
Okay, so some people in the chat have other opinions, all right? Any of the people
calculate the gap, so
let's calculate the gap. So now we have to do math.
So it's 32. So this is high anion gap.
Okay, so is that all that's wrong? So the patient has a increased anion gap acidosis. Is there something else?
So do we have VBG or blood gas?
We will get your blood gas in a second, but just from the electrolyte panel, what else do you want to get out of this? There's a lot of information here, and the reason we're doing this is because if you carefully analyze this this electrolyte panel, you're starting to build a picture of the patient and how you're going to go about treating the patient and further evaluating the patient.
Yeah.
Okay, so let me go through some of the thought process here. First of all, the sodium is low. Why would the sodium be low? Why do people get low sodium? So when I think about low sodium, I think about volume contraction, euvolemia, and edematous states. We have a lot of evidence this patient is volume contracted, right?
Yeah.
We have tachycardia and a decreased blood pressure. I don't think it's shocky yet, and I don't think this patient was admitted to the ICU when I saw her. It's hard for me to remember because it was over 8 years ago. So why do people who get volume contracted get hyponatremia? So this is a great learning opportunity. Okay, chat, why do people who are volume contracted get hyponatremia? So there are a lot of people who are getting all excited that this is beer potomania and decreased solute intake. And that would certainly be a possibility, but that's not why people who are volume contracted get hyponatremia. And the reason is Alexander Smith, congratulations. So what happens is volume contraction stimulates the baroreceptors and it tells the pituitary to produce ADH. So this is a physiologic increase in ADH. everybody who's volume contracted, and you know this, if you ever go out and run or play sports when it's hot outside, and then you go to pee, it's very dark. It's very dark because you've stimulated ADH. So the question here is, some people thought it might be potomania. Some people thought that it might be volume contraction. So the question is, how are we going to sort those two things out? So at some point in time, we're going to need some urinosms. Okay, now we have an anion gap of 32. Now we were expecting a metabolic alkalosis, right? Vomiting gives metabolic alkalosis.
Yeah.
So how do we resolve this? Well, for someone who has an anion gap of 32, isn't that a pretty high bicarb?
Yes.
So if we do the delta gap, so Stephen is going to do the delta gap for us right now. We would expect a gap of around 12. So we have an excess of about 20. So if we add that 20 back to the chloride, we see that the patient probably has a chloride, a true bicarb in the 40s. Doesn't matter how you do some people do delta, some people do delta gap and add it back. But either way, this defines an anion gap acidosis and a metabolic alkalosis.
So it's mixed disorder.
It's a mixed disorder. We don't need a blood gas for that. In fact, blood gas doesn't help us figure that out.
No, it will be compensated sometimes.
Yeah, no, we'll check that in a second. But I want to make sure we get everything out of here before we go to the ABG.
Mm-hmm.
So that makes a lot of sense. And people who vomit often have a mixed disorder.
Mm-hmm.
And the reason they have a mixed disorder is because the vomiting causes a metabolic alkalosis, and the volume contraction ends up causing some lactic acidosis and some ketoacidosis. This is a very common combination in clinical medicine, especially with alcoholics. Excuse me, that's incorrect. That was politically incorrect. Patients with the propensity to drink too much alcohol, that's much more politically correct. If they have alcohol use disorder, they often will present with this combination. And so this is not an unusual combination when you're actually taking care of patients, right?
Mm-hmm. Yeah.
Okay. Now, another suggestion this patient might be seriously volume contracted is the BUN to creatinine ratio. Especially in someone who's not eating well, you expect a lot of people who drink a lot to come in with very low BUNs. And sometimes we'll see a BUN that's 2 or 3 or 4 or 5, but not 32. The other thing that I would think about is, let's make sure this patient's not bleeding. And I'll tell you now, this patient was not bleeding. So this is just severe volume contraction. Now, this patient also is at big risk. We have to be real careful, and some people in the chat talked about that. We're going to be at risk for, if we replete the potassium too fast and the sodium too fast, what are we at risk for?
If we repeat the sodium too fast, usually we'll have the central pontine demyelination.
Right. And just to remember, it's particularly the pontine, but it can be extra pontine also. Mm-hmm. So it just causes it's just the pontine is the most likely one to have it.
And I feel like even people with alcohol use disorder, sometimes they correct too fast, even without giving them much of a fluid.
Yeah, this patient is really at risk for responding too fast, if in fact this is ADH, because as soon as we give enough fluids, we're going to turn off the ADH, and then she'll start peeing out dilute urine. Mm-hmm. If in fact she's starting out with concentrated urine. But that potassium really has us scared. What other electrolytes do we worry about in someone who has a low potassium?
We should check the magnesium and the and the phosphate sometimes goes with the potassium.
Absolutely. And we're worried about a refeeding syndrome
Mhm.
in this patient because of the vomiting. And we don't want to miss the phosphates. Now, when I wrote this up, I wasn't as obsessed with thiamine as I am today, but obviously we're giving this patient a lot of
Yeah.
thiamine.
Mhm.
And if in fact the patient's thiamine deficient, that could be a cause of some of the lactic acidosis. That's we don't talk about that all the time. Anne Marie had just typed that while I was saying it. Thank you, Anne Marie. So we're going to give big doses of thiamine, and we're going to check phosphate. We're going to How fast can we give the potassium? Now we've done that at Unremarkable Labs before, but one of the things I learned about medical education is you almost can't repeat lessons too many times. Saying it over and over again. Usually, if for those of you who are residents and attendings who are teaching students and interns, I want you to remember that no matter how brilliantly you say it, if you ask your learners a week later whether they the same question, they'll miss it about 2/3 of the time. And so repetition, it seems like you're repeating yourself a lot, but it's worthwhile to repeat yourself a lot. So in Buffalo, how fast would you give the potassium?
I'll give the potassium and then we check it like very even like every 4 hours. So
Yeah.
I'll give them 10 milliequivalents, and that's per hour.
So,
IV.
so yeah, so you can make a case for 10 if you have a really good vein. I tend to go a little bit slower than that just because I'm worried about uh, tearing up the veins, but you can go as high as 10. Um, as I remember, this patient did not have any significant cardiac abnormalities at the time, and we don't want to replace the potassium too fast because the potassium plus the sodium is our risk for pontine demyelination.
Mm-hmm.
Now, what fluids do you want to give?
So so we'll check his serum osmolality, but I'll start with normal saline. Um,
Mm-hmm. And so
Lower
this,
rate.
yeah,
Um,
this is one of the situations where normal saline is exactly the right thing to give.
mhm.
Uh, more and more I've switched over to lactated ringers, a balanced solution, but not in this case because, as Anne Marie said in the chat, this patient has a really low chloride, and you really do have to replete the chloride, and so you do need to give normal saline in a metabolic alkalosis if we prove that this is all due to the vomiting. So, what questions do you have? So, I just want to make sure that everything that I said makes sense uh, to you. So, do you feel like you have a better understanding of all the things we can get from this page, from these numbers so far?
Yeah.
Okay, so people wanted the blood gas. The blood gas is actually very interesting. Steven's going to type it in for us, and I'll
Yeah.
let you. And we got a blood gas. This was 8 years ago. I wasn't getting VBGs back then.
So the AVG should have pH of 7.6, with a CO2 of 26, O2 of 100, and a bicarb of 21.
And that's on room air.
Interesting. This the pH is alkalotic, so it's 7.6.
Mm-hmm.
The CO2 also, it's in the lower side.
Mm-hmm. So this is a surprising blood gas, isn't it?
Yeah.
So
Was
what
the
was it?
patient, yeah, I was about to ask if the patient have other symptoms. What other symptoms was reporting?
Just don't remember because it was 8 years ago. I could say that I could tell you that she had a positive Trousseau's even without taking her blood pressure, and sound like I was really smart, but I just don't remember. So what does that PCO2 26 tells us? So if we do the Winner's equation, right?
Yeah.
Do the Winner's equation with a bicarb of 21, what should the PCO2 be?
I'll calculate.
If you'll calculate. Okay, go ahead. Take your time. Nargis is doing such a good job.
21. So it's 32 plus minus 2, so it would be 41. So 32 to 42, basically.
Yeah, 32 plus 8 plus
39
minus 2.
to 42.
So this is clearly a respiratory alkalosis.
Mm-hmm.
So it's good that we have an arterial blood gas, because anytime you're looking at a respiratory alkalosis, you have to ask yourself, is this because the patient's having to hyperventilate to get enough oxygen? This is not a very high AA gradient. So this is decreased oxygen is not the stimulus. There's some other stimulus for this person to have a respiratory alkalosis. So what on the test, what do you have to think about? And actually in real life, what do you
He's like, because of the anangab metabolic acidosis, usually you have compensatory respiratory alkalosis. The patient's like taking, like, he's basically hyperventilating.
Right, but why is the patient hyperventilating?
It's a compensatory mechanism with the high anangab acidosis.
So that's where the Winner's equation helps us. The Winner's equation says this is not a low enough bicarb to cause that much hyperventilation.
Oh yeah.
So the chat is on fire over here. They're just going nuts. Okay, so here's a rule for everybody to remember. The first thing you think about, because there's an increased anion gap acidosis, there's also metabolic alkalosis, and there's a respiratory alkalosis. So when you see anion gap acidosis and respiratory alkalosis, what do you have to ask about?
Aspirin.
Right. The patient was not taking aspirin. And we got a salicylate level, and the salicylate level was 0. So there's something else, and I think by the end I can tell you what.
Yeah, there is something else. I cannot remember now.
There's something else going on. So let's go ahead. You ask for some other things. So why don't we tell you some of the other labs that we got?
Okay.
So some people want to know what's going on in the urine. So we got a serum osm. I don't have the urinalysis recorded from this patient, but the serum osms were decreased to 259, so it's real hyponatremia. But the urine osms were 411. So some people were thinking this was going to be very low urine osms, beer potomania, but in fact, this is volume contraction. This is increased ADH by definition, right?
Yes.
So then we want to know about the hypokalemia and vomiting. So the question is this really vomiting, or is this some kind of an aldosterone mechanism? So, and this actually helps in a lot of ways. The urine sodium was less than 10. The urine chloride was less than 10. And the urine potassium was 45.
So the urine sodium would go with the hypovolemia.
Right. And actually, with the metabolic alkalosis, the urine chloride is a little bit better, but we could use either one in this case, right? So this patient appropriately is trying to hold on to sodium and inappropriately wasting potassium because the volume contraction causes aldo cause all kinds of reasons to reabsorb sodium, and therefore you waste potassium.
So it's not really significant. I mean, it's a little bit high.
Yeah,
but we can check aldosterone to see if it's related to it.
Well, the patient's in a high aldo state, and this is why people who get severely volume contracted from vomiting get hypokalemias, because they waste potassium. But we know that this is volume contraction because they're not wasting chloride. So if it was pure aldosteronism, they'd have a high urine chloride also. Okay. Does that make sense?
Yeah, it makes sense.
Okay. So then we get to the meat of the matter. The magnesium is normal. It's 2.5. And I always tell people just empirically give magnesium, even if it's slightly low, but that's just stone cold normal. Mm-hmm. And one clue that this might not have had anything to do with magnesium was that the calcium was normal. So with severe hypomagnesemia, you often get hypocalcemia also.
Yeah.
So I don't think we didn't feel like we had to give this patient magnesium. And then the phosphate was the main reason we're presenting this case. Go ahead, Stephen.
0.7.
Wow.
So how many of you have seen a phosphate of 0.7?
I don't remember if I saw this low.
That's really low, especially on admission. Sometimes it'll go this low when the patient is given glucose initially. Remember, you don't give glucose to someone who with an alcohol use disorder when they first come in because of the thiamine and because of the phosphate, because of a refeeding syndrome. So this is really dangerous. I have seen someone die from hypophosphatemia. So we're going to have to give phosphate, and nobody remembers how to give phosphate. So we're going to go over that because I have it written down, but let's first remind ourselves, all the things we have to worry about in this patient because of the hypophosphatemia. And so would you like to hear my hypophosphatemia 5-minute lecture?
Yeah, sure.
Okay. 5 minutes on hypophosphatemia, which remember, we mostly see this in refeeding. So you'll see this in anorexics, you'll see this in cancer cachexia, you'll see it in diabetic ketoacidosis, and you'll see it especially in people who drink a lot of alcohol because alcohol causes phosphaturia. So I do this, and if you're watching me on the screen, I start out with the brain. We need ATP for the brain to work right. So you can actually die from seizures, and you can definitely get altered mental status. So one of the reasons to correct this is to prevent the problems in the brain. The next thing I always think about is the heart. This is the patient that we did an M&M on up in Huntsville a number of years ago, had a cardiac arrest, went into VFib. And that's fairly common. It also, remember, we need ATP for muscles to work, so you can actually go into acute heart failure from hypophosphatemia. There's even a theory that one of the reasons that you could totally recover from alcoholic cardiomyopathy is that they have intracellular hypophosphatemia, and that when they stop drinking and they replete their phosphate, that's why the muscle gets back to normal. I don't know if that's true or not, but it's a nice story to tell. Then the lungs, you get respiratory problems because the muscles are weak. And so people can get respiratory failure. Then the muscles themselves, you can get rhabdomyolysis. Now, if the patient had rhabdo, we didn't see any evidence of that in the urinalysis, as I remember now in this patient, and the creatinine is really quite normal. And then the last is in the hematological system. You can get hemolysis because you need ATP to maintain cellular structure, and you're more prone to infections because the white cells don't work as well. So a great question from Vishnu in the chat is the low phos causing that hyperventilation? And that's what we thought, because this all got better as we repleted the phosphate and repleted the potassium. Now, I actually, I wrote a blog post about this a number of years ago, and here's from an article, and let me give you let's see if we can get you the reference for the article. I'm going to put it in the chat right now. Cite this article. This is from 2006. Okay, so there you go. There's a citation of an evidence-based approach to hypophosphatemia. And what they point out is that with severe hypophosphatemia, and this is severe hypophosphatemia, in a critically ill patient or with clinical sequelae of hypophosphatemia, intravenous replacement at 0.08 to 0.16 millimoles per kilogram over 2 to 6 hours. So it's an open access article. So it's probably a worthwhile article for you to have if you keep articles on your phone or on your internet computers, you can pull them up fairly quickly. I treat everything between 1 and 2.5. But you don't treat them quite as aggressively. So I don't worry about above 2.5. I don't worry. I just want them to eat, because as long as they're eating food, they're going to get enough phosphate. The only time eating is dangerous is when it's already really low. The other thing that we did in this patient, we checked the CKs, and the CKs were normal. Everything got better with saline, potassium, and phosphate. So what I'd like the chat to do, and what I'd like Nargis to do now, is think about the important lessons this brings you in terms of looking at the labs and thinking about how to take care of patients who come in with this kind of set of numbers. What are the lessons that people are getting out of this? So I'd appreciate stuff in the chat. And Nargis, why don't you think about this for a couple of minutes, and then I'm going to let our great chief residents, Drs. Alon and Carter, both comment also. I'm waiting for brilliancy in the chat. The chat is totally ignoring me. Okay. So
I'm not ignoring you. I'm gonna tell. I actually find this case really interesting, especially with the hyponatremia. Everyone jumped because of the demographic of the patients. They basically jumped to the beer proteinemia, and it's clearly was volume issues with the sodium. So usually we should keep like our differential diagnosis broad, especially in certain condition, or the patient like this guy is like this lady, she's actually critically ill with the hypokalemia, and we should keep in mind always to check for phosphate in such conditions. Because that can be severely dangerous. And sometimes if you replete, I've seen before, if you replete the potassium without checking the phosphate, the patient just will be like hypokalemic, because if you do not correct their phosphate, their potassium will not be corrected. So I think this thing, just to keep in mind the phosphate, you have to check it to correct their hypokalemia.
When I'm on the wards, I have a rule that if someone comes in who's been drinking heavily, we check the phosphate on days 1, 2, and 3. Because this was unusual that she came in with low phosphate, but often they don't develop the hypophosphatemia until the 2nd or 3rd day. And the same thing if you have someone who has been anorexic, either because of cancer or for whatever reason, and start eating, just worry about hypophosphatemia being the most dangerous part of the refeeding syndrome. Travis was found it very helpful that we looked at the delta gap. Here is what I hope you remember from this. And I'm looking at you, Drew, because I really want Drew to remember this. If you have a big anion gap and a not very low bicarb, that's going to be a metabolic alkalosis and an anion gap acidosis. So with it, just remember, with an anion gap of 32, your bicarb should be somewhere less than 10. So if it's up at 21, that's a red flag. Most people don't think about that. Most people don't think about that. So that's a big clue. Anne Marie had previously said she'd never seen a chloride this low. I have seen patients with bicarbs higher than their chloride a couple of times. When I wrote this up, I didn't talk about how you make sure that the sodium doesn't go up too fast. We had to give enough, you'd have to give enough normal saline to stabilize the patient, get the blood pressure up. And the question is whether you would actually give ADH. From at 120, you're not very likely to get demyelination disorder. It's usually lower than that, but I would have been concerned about this. Travis, that's a great question. How much potassium? So I've tried to read a lot about what the potassium deficits are. And here, this is the latest thing that I read. To go from 4 to 3 means you're down about 100 to 300 milliequivalents. But it's not linear, it's curvilinear. To go from 3 to 2 is an extra 3 to 500 milliequivalents. So this patient's approximately at 2, so we're going to have to give a lot of potassium. Now, the key here is to try to get the potassium up a little bit with either 5 milliequivalents an hour or a little bit more, no more than 10. And then once it's coming up and the patient is no longer vomiting and we can start giving the patient oral potassium, I'd rather correct it with oral potassium. But it's really, you can only guess how much potassium. Now, if you have access to potassium phosphate, giving this patient potassium phosphate is brilliant because we're taking care of both things at once. Alexandra asks how quickly to replete the phosphate. As long as you're checking in and don't think that you're going to run the problems of hyperphosphatemia, I think how fast to do it is exactly what that article said, and I could read it again for you if you want me to. But it was what they recommended, which and I think this is really a great article to fall back on. So let's see this. Let's say this patient was 60 milliequivalents. It would be 60 kilograms. So it'd be between 0.5. Let's see. I got to do my math. It'd be 5 to 10 millimoles over the next 2 to 6 hours. You actually give it fairly slowly. The pharmacy will help you, but the pharmacy is going to be nervous about giving it as fast as you really need to. They may question that, and I have had patients where we had to convince the pharmacy that it was okay to give it at this rate. So I hope that was helpful. And given that tonight is a night that Drew is very nervous about this election for some reason, I think we're going to finish a little bit early. But I'd like Stephen and Sean to give some of their thoughts, and they had read the case ahead of time, but just some of the thoughts of things that you've seen since you've been a chief resident and that you experienced during your residency.
Yeah, happy to. So, like Nar just said, there's something about this BMP that just screams alcohol, even without ever meeting the patient. That hyponatremia, hypokalemia, low chloride, when you see that, you already know volume contraction is probably at play. Something that I have learned this session that I did not know about was the relationship between hypophosphatemia and respiratory alkalosis. And so that's something I'm going to be considering in the future when I see that. The one thing I was wondering about, Dr. Centor, given that she was vomiting and she had been drinking heavily previously, I wonder, do you think withdrawal could have contributed to her respiratory alkalosis?
Absolutely. Absolutely. This could have just been her withdrawal, and certainly with her pulse being 120, we could make a case that was withdrawal, but we could also make a case of her volume contraction.
Yeah.
The key thing is that as we gave her phosphate and gave her fluids, her respiratory alkalosis disappeared. So whether it was volume contraction, whether it was her withdrawal, or whether it was the hypophosphatemia, or some combination of all that.
Mm-hmm. Yeah.
Sean, are you able to speak?
Yeah, I can speak a little bit now. So I think there's kind of three things that I want to point out. The first one is definitely echoing Stephen with the hypophosphatemia and the respiratory alkalosis. That wasn't something that I was previously aware of. The second thing is never overlooking an anion gap and the delta gap, because the bicarb in this, I think, would have tripped a lot of people up into thinking that this lady was actually a little bit better than she was. And then the last thing is just reminding people that when you have somebody with significant hyponatremia, don't be afraid to be checking repeat labs early and often, especially as you're giving them fluid, because you run into problems if you're not checking it frequently enough.
Great. If anybody has any other questions, otherwise, we're going to declare it too early to call. The crucial battlegrounds, according to CNN, which I have on over in the corner, and I've been sneaking peeks of while I was talking, it's all too close to call. So Drew, I know you're nervous. We're going to blame it all on Travis. Whatever happens, it's all Travis. Can a patient have a normal anion gap and metabolic alkalosis at the same time? You wouldn't know, Vishnu. That's a great question, but you might not be able to figure that out. They actually could balance them, so they could balance each other out. The only way you can get a double is to have an anion gap acidosis. You can have an anion gap acidosis and a normal gap acidosis, or you can have an anion gap acidosis and a metabolic alkalosis. But you could probably come up with you probably get someone who has an RTA and vomits enough to get a normal looking numbers, but you could only figure it out in retrospect. Great question. Thank you all so much. We hope we're going to do a night float case next week. I'm working with Mohit and Alonzo to hopefully do that. Y'all have a great evening, and don't stay up too late looking at the election returns, because it will only cause anxiety and panic disorder. You get panic disorder.
I mean, I also have residency interview invites to look forward to, so double the anxiety.
Okay, and before I forget, can we have a round of applause for Nargis? Nargis, thank you so much for helping us with this, and hope that you learned a whole lot, and you helped everybody else learn a lot, which was great.
Thank you so much.
Good luck. I hope it doesn't snow too much, but that's sort of a silly thing to say to somebody who lives in Buffalo.
We're used to it. Thank you.